So welcome to the session for Tier 2 for the WET workshop. And just wanted to remind everybody to ensure that your microphone is muted. I do have the ability to mute everybody, but I'm just hoping that you guys can do it on your own as you're signing in, or if you've noticed that it's unmuted. When it comes to answering the questions later on, after Dr. Mack has done his presentation, you have the ability or the option to enter your question in the Q&A portion of the Teams chat, or just to go through the chat. And you also can raise your hand, and once you raise your hand, and we'll go through in order of who's raised their hand, and just unmute yourself to ask your question. And I just would like to introduce Dr. Jonathan Mack, who is a physician here at the Ottawa Hospital with the Earla Group, and also a medical officer with Canadian Blood Services. And he will be going over all the case studies with you this afternoon. So Dr. Mack, if you want to take it away.
Thank you very much. You can hear me okay?
Yep.
Okay. And slides are showing up all right again?
Yep.
We have to go through the check every single time. So thank you. Welcome to those of you joining us for Tier 2, and welcome back for anyone who was with us for Tier 1. Apologies to the people who are in Tier 1, just to have to be repetitive, but I want to make sure that new people joining know about all the hard work from people other than myself that went into creating the workshop for today. So that includes on the ORBCoN side, Tracy Cameron, who's helping to moderate today and has also been involved with making sure registrations were set up and helping to answer email questions and tons of other things like that. And Valerie Rayom and Sheena Sherman, who've also helped with a lot of the planning on the ORBCoN side and making sure we're ready for today. And then on the Neural, the National Reference Lab, and the CBS side, Jackie Cote and Tammy Icing, who've helped with question development and coming up with some of the scenarios and prepping the samples, and then Lise Kemp and Carmela Pote and Tony Lin at CBS Neural, who have helped with getting the samples ready, shipping them out. Tons of effort that went into that. There were about 60 samples, 45 to 60 samples total that were shipped out for the workshop. So just a lot of work, and just want to make sure that gets acknowledged. And a big thank you to everyone who helped prepare for today's workshop. So with that, we'll go on to case 1. And this year's workshop, we had a 1 sample for Tier 2, which was provided with the stem. So the stem was a prenatal sample from a 33-year-old G3P2A1 patient, 3 prior pregnancies, currently at 28 weeks gestation. And the patient has no known prior history of transfusion, denies anything in the past, with all of her pregnancies being with the same father. And we provided 2 samples, one from the mother and then a sample of paternal RBCs, just to help with the investigations. The situation for this case was just because obviously you're not routinely getting paternal cells, but we anticipated potentially some challenges with the routine serologic approach to it. So I want to provide the RBCs from the father just to give a bit of stimulate some of the additional testing that might be done. So the sample, some of the key things from the sample stem, I think just worth highlighting, is that it's a prenatal sample. So this is, raises the concerns about HDFN, not so much for transfusion, but from the HDFN point of view. This is a patient who's got prior exposures through pregnancies, and the fact that there's no transfusion history really kind of leads us to think that any sort of alloimmunization events that would happen from a red cell point of view would have been through pregnancies. And if they're all from the same father, then really that paternal antigen status phenotype is going to be where sensitizations could occur through, indirectly through the fetus. So those are all sort of the important pieces of the stem. So first question was just around what are you actually seeing in the test tube? So what results were obtained on antibody screening? And this one, so 34 of the answers we got were negative antibody screening, and 10 were positive. We were expecting on this one a positive result, although not entirely surprised by the results. When we get to the antibody, the actual antibody ID that we had, we were trying to make it an interesting scenario and something that maybe is not commonly encountered, but mindful of the fact that screens may not pick up what we were expecting people to pick up with this one, which is partly why we added the RBCs from the father and encouraged you to be testing those if the screens were coming up negative. And that has to do with the specificity that we were expecting. So the antibody specificity that we're expecting, 50% of people got it, which was an anti-KPA. So that was what we were expecting in that sample. And again, we were mindful of the fact putting the workshop together that the not everybody's screens out there would necessarily have a KPA positive cell on it. So that's why we were nudging you a little bit with the paternal cells, and for a few people that had reached out wondering why they were getting an IB screen, what they were supposed to do with it, to get that testing done between the father cells and the maternal cells, even though that wouldn't be done in sort of routine practice. This is sort of more just to help with the activities of the workshop. So with that in mind, the question was, why are there any concerns to be concerned, or are there any reasons to be concerned about HDFN in this pregnancy? Why or why not? So about half of people kind of answered something related to HDFN. You can see in the word map here about what's some of the other answers that were received. But what we were really expecting was that, yes, this mother has an anti-KPA antibody, and since that's incompatible with the father RBCs, there's a concern about HDFN, particularly because anti-KPA is an antibody that can cause HDFN. So not all red cell antibodies are associated with HDFN, but anti-KPA has been associated with HDFN. So that was really kind of what we were hoping people would get with this one. So that's the answers to the samples that we sent out. In terms of the next question we had was just kind of a little bit more of a survey around what are people actually doing out there, and just kind of interesting to see what responses were for here. So in terms of what respondents use at their hospital as their primary detection for unexpected red cell antibodies, it's a bit of a mix between solid phase and gel, which is what most hospitals are using. A few hospitals using just tube, and from the information provided, I couldn't actually tell whether it was which platform was kind of being used for 6 samples. But so for the participants in this workshop, we had about even split between solid phase and gel that's being used. In terms of whether or not hospitals are using an auto control routinely as part of their antibody screening, majority actually don't use an antibody screen, but 2/3 don't, and 1/3 are using an auto control routinely with antibody screening. Guessing some of those are probably because of the auto controls not being easy to do with the solid phase methodology, but only 18 hospitals that are using solid phase and 28 that aren't doing the auto control. So I don't know if that explains it entirely, but interesting to see that. And in terms of whether or not secondary methods for detection of unexpected red cell, what methods are used for unexpected red cell antibody as a secondary method, most commonly answered was PEG in terms of what people are doing out there. But there was a fair amount of variability in terms of whether it's PEG, whether it's SIDAT, tube method with saline, sort of a bit of a mix, and not really a strong, clear secondary winner other than PEG in terms of what labs are using. So that was like kind of just sort of interesting to see what people are doing in terms of the actual questions that we'll get into. The first question we had about the samples were, which of the following is most likely to be useful in the interpretation of an antibody screen? So our options being the saline indirect antiglobulin test, SIAT, use of reagent red cells expressing a low incidence antigen, DTT treatment of patient plasma, or the auto control. In terms of responses that we got, it was a bit of a split between the SIAT, use of low incidence antigen red cells, and the auto control. In retrospect, this might not have been the best kind of question. I think we were expecting as an answer the auto control. I think this is kind of the most likely to be useful when you're interpreting antibody screen, is that if you have a positive screen, if your auto control is positive or negative, that's really going to kind of guide you into thinking about possibly an alloimmunization event and some circulating transfused cells if the patient's being transfused, or in the absence of transfusion history, more of an autoantibody and kind of guiding testing there. So that was, I think, kind of the thinking behind why we wanted auto control as an answer. The SIAD, I can understand why people answered that. I think that kind of, if you're thinking just in terms of like what methodologies would you use if you do SIAD on a panel, that might be kind of something that's helpful. But just as a method on its own, SIAD like isn't really all that helpful. Like just doing SIAD for an antibody screen, there's no reason why that's any better than doing gel testing, for example. But I kind of understand just a little bit of vagaries in terms of how that question might be interpreted. In terms of B and C, those can be useful in interpreting an antibody screen. So, use of low incidence antigen or a panel with low incidence antigens might be helpful if you're really suspecting a low incidence or an antibody against a low incidence antigen. But those aren't going to come up all that frequently, and so may not be the most likely to be useful. They're going to be useful in some circumstances, but not in a majority of circumstances. And DTT treatment of patient plasma can be helpful. The reason we would do this would be that DTT dissolves the disulfide bonds and so disrupts IgM antibodies, so it can get rid of interfering cold antibodies, or if there's an IgM component as an alloantibody that's emerging, can help to clean that up, and might help if there's a complicated kind of panel with some interfering antibodies or multiple antibodies in there, but not going to be useful as sort of a first step, and not going to be useful in all scenarios. So not as good an answer as the auto control, I think, is kind of the rationale behind that one. Next question was, which of the following is not included in the definition of a clinically significant red cell antibody? So the options here were an antibody against an antigen expressed by 95% of the donor population, an antibody associated with decreased red cell survival following transfusion, but no acute reaction, an antibody that's been associated with hemolytic disease of the fetus and newborn, or none of the above. In terms of responses we got here, a lot of people suggesting none of the above that fit the definition. And then antibodies against an antigen expressed by 95% of the donor population. I guess not included is kind of just to emphasize that here. So we're looking at which of these doesn't fit with the definition, and the best answer here is the antibody against 95% of the donor population. That's the definition really of a high incidence antigen, or getting towards the definition of a high incidence antigen. Nothing to do with the clinical significance of the antibody, more about the frequency of the antigen expression. And both B and C are included in definitions depending on where you look. Just for reference, the CSTM standards definition of a clinically significant antibody is red cell antibody is an antibody that has a potential to cause harm to transfused patients or to affect their management and treatment. So relatively broad, anything that might affect their management and treatment would be included in there. And the AABB definition includes antibodies that have a specificity that are associated with HDFN, with a hemolytic transfusion reaction, or with a decrease in red blood cell survival. So any of the above. So both options, B and C, kind of are included in the definition. So not great answers for this one. And obviously, because B and C are there, none of the above doesn't make sense as an answer. So that's why A is a suggested answer there. Next question was, which of the following must be performed with investigations for clinically significant red cell antibodies? Options here were a minimum of 3 reagent red cells for antibody screening, 37-degree incubation prior to antiglobulin testing, pre-warming to avoid interference by clinically insignificant antibodies, or the addition of an enhancing medium. So which one is required? In terms of responses, we got almost everybody responding 37-degree incubation prior to antiglobulin testing. A few people thinking it was at the minimum of 3 reagent cells, and 1 answer each for C and D. And the suggested answer here is a 37-degree incubation. This comes from our CSTM standards, which don't require 3 reagent cells, but a minimum of 2 reagent red cells expressing the wide variety of blood group antigens for screening. And you can see in the standard 5.3.5.2, the incubation at 37 degrees, followed by any antiglobulin method is recommended. So that's what's making the option B here the best answer. Pre-warming is not a requirement and can actually lead to maybe falsely making clinically significant antibodies go away that we might falsely attribute to being autoantibodies or interfering cold antibodies. We don't necessarily know if an antibody goes away by pre-warming that it isn't a meaningful antibody or that it is an autoantibody. And the addition of an enhancing medium can be helpful, but isn't required when we're screening for red cell antibodies. So that's why B was a suggested answer there. Next question, based on antibody screening results for the provided sample. So again, just as a reminder, we're talking about the sample showing, expected to be showing an anti-KPA. Which of the following is true? Our options here are red blood cells that are ABO and RHD compatible are sufficient for transfusion. So we don't really have to worry about anything other than just ABO and RHD compatible red cells. Additional tests with D negative red cells are expected to be negative. C, additional antibody identification testing is required before any red cells can be issued. Or D, over 95% of ABO compatible red blood cells are expected to be incompatible. So in terms of responses we got here is a bit of a split between additional testing being needed, that's in green, and the red blood cells that are ABO and RHD compatible being sufficient. Our suggested answer here is C. I can understand why A was answered by a lot of people. If you weren't seeing the reactivity on your screening, you're getting a negative screen, saying, well, there's no antibody here, so we should just issue ABO and RHD compatible. But if you're picking up that anti-KPA, then really that's obviously not the right answer, and we need to do additional testing to figure out what is the specificity of the antibody on that screen that we're picking up. So that's why C here is the favorite answer. Additional testing with D negative reagent red cells, I think obviously it's kind of a reasonable answer. The spirit behind that answer was really like, thinking like, well, is this a D specificity, and is using D negative red cells going to get rid of it? Which the answer to that is no, which is why it's not a great answer. But in reality, since KPA is a low incidence antigen, you're probably going to get negative reactions with just random D negative cells because they're probably not going to be KPA positive. So I think that can understand why that one might have trumped some people up. And then over 95% of ABO compatible red cells really shouldn't be incompatible because KPA is a low incidence antigen. We're not expecting 95% of cells to be expressing it. So that's why D is not a great answer. Next question was, which of the following is true of the antibody specificity identified in the patient sample? So we're hoping people were identifying the anti-KPA. And options here were reactive reagent red cells treated with Ficin are expected to be negative. So is KPA enzyme sensitive or not? Reactive reagent red cells treated with DTT are expected to be negative. So is it DTT sensitive or not? They're expected to be positive after Ficin, or both B and C. Split here with answers with most people answering both B and C, so that expecting that KPA would be sensitive to DTT and not affected by enzymes, and that was the expected or suggested answer here. The information, if you're identifying the KPA, it should be pretty straightforward, but KPA is a resistant to Ficin and papain, so those positive reactions should stay positive, and it is DTT sensitive, as being in the KEL group. DTT will remove it, so any positive reactions would be expected to be negative afterwards. So both B and C are right, which makes D the best answer. In terms of the information, question is, what is the information does the auto control provide? So there's a question about auto controls. So the options here were presence of autoantibodies in a transfused patient, presence of antibodies that react with red cells from the patient, discrimination of antibody against a high frequency antigen from an autoantibody, or both options B and C. See here for the responses, most people thinking B or C. The few people answering just the presence of antibodies that react with red cells from the patient. In terms of suggested answer here, B or C was favored. The auto control, we're taking test patient plasma and reacting that with RBCs from the patient sample. So being careful to say that it's not the patient's red cells, but patients from the patient sample, because they might be transfused cells. And we're using the same conditions as the test RBCs to do that. So if we have an autoantibody in a transfused patient, we're not going to necessarily be able to detect the autoantibody part because we don't know if they're transfused cells or patient cells. The autocontrol might be positive because of an alloantibody against transfused cells. So we can't really distinguish auto from allo in a transfused setting. So that makes A not a great answer. And then both B and C are possible answers. Any antibody against the red cells from the patient, not the patient's red cells, but red cells taken from them, could be positive, could result in a positive autocontrol. And if you're just trying to discriminate an autoantibody from a high frequency antibody against a high frequency antigen, like a Bombay situation, really the autocontrol is very helpful there. So both B and C are good answers, making D the favorite answer here. Next question was, what information do you need to properly interpret the autocontrol? So the options here were the results of direct antiglobulin testing, a complete transfusion history from the past 3 months, or the results of both saline indirect antiglobulin and PEG enhancement autocontrol. So not just the autocontrol, but different methods of the autocontrol. In terms of responses here, we had a lot of people answering results of the direct antiglobulin testing, followed by transfusion history from the past 3 months, and a few divided between B and D. In terms of our expected or suggested answers, the transfusion history from the past 3 months, that was the most helpful in properly interpreting the autocontrol. The results of DAT testing are helpful in interpreting the autocontrol. But before you get to looking at the DAT testing, like if you don't know whose cells are possibly in that sample, if they're only patient cells, or if it could be a mix of patient and transfused cells, it's going to be difficult to really interpret any further testing. So the favorite answer here is really kind of first establishing what the transfusion history is as the next step in your autocontrol. And just as a reminder, in terms of what can cause a positive autocontrol, it could be due to autoantibodies. It could be warm, cold, or drug dependent. An alloantibody in the setting of a recent transfusion, or non-specific binding from paraprotein, or an antibody against the medium that you're using. And how the autocontrol and the DAT differ, even though they're sort of getting at the same things, the DAT is really detecting in vivo RBC sensitization, so coding of the RBCs with IgG or C3 in vivo, you're picking that up. Whereas the autocontrol is not looking for that in vivo sensitization, but taking the patient red cells after having washed them and then testing them with the patient's plasma, so allowing more in vitro sensitization to occur and seeing if that's there. So it's the in vitro versus in vivo difference that differentiates the two, which are similar but not exactly the same information that you're getting from the two. So which of the following is true of the antibody specificity identified in the patient sample? So again, this is the anti-KPA was what we're expecting people to be finding here and working with. So the antibody will interfere with cross-matching for most ABO-compatible RBC units. IAT cross-matching of ABO-compatible units that are not typed for the antigen is an acceptable way for identifying antigen-negative units. The rare blood program should be contacted to help identify antigen-negative units, or the antibody is not clinically significant, and so we don't really have to worry about it. So in terms of answers here, majority of people getting the suggested answer, which was that you can use your IAT cross-match of ABO-compatible units that aren't typed to try and identify an antigen-negative unit here. Again, just as a reminder that this is the anti-KPA we're talking about. So that was the suggested answer for this question. KPA is a low-frequency antigen. It's present in less than 2% of donors. Depending on ethnicity, it's either just under 2% or way under 2%. And it is clinically significant as it's been associated with both HDFN and hemolytic transfusion reactions. So D is not a right answer because of those associations with clinically significant reactions. It's a rare antigen, so we don't necessarily need to be contacting the rare blood program to try and find negative units, because a lot of units are going to be negative for it. And as long as you have a detectable KPA in the patient's plasma, you can use that plasma as a way of identifying KPA negative units through your cross-matching. So that's why B is the favorite answer here. A obviously is not favorable because it's a low incidence antigen, and so it's not going to interfere with cross-matching for most compatible units. It'll be few compatible units that will be interfered with by the KPA. So for a patient with a positive antibody screen, a positive autocontrol, and a negative DAT, which of the following should be considered next? The options here were autologous adsorption, allogeneic adsorption, eluate testing, or repeating the DAT with prolonged 37-degree incubation. In terms of answers here, we had autologous adsorption as the favorite answer, 28 people answering that, eluate testing by 10, and then a few answering the repeated DAT with a prolonged incubation, and allogeneic adsorption by 5 people. Favorite answer here was autologous adsorption. Why that is first, I guess the autologous adsorption, if you can do it, is going to be the easiest to do, potentially, depending on the patient's hematocrit. So in terms of what would you consider next, I think since that's easiest to do, that would be the first next thing to think of. You'd have to establish what the transfusion history of the patient is before you consider that, because if they've been transfused, then obviously an autologous adsorption wouldn't be an option, and you'd have to then think about doing an allogeneic adsorption. That's why the asterisks are next to that one. Eluate testing here, it's a negative DAT, so eluate testing wouldn't be the top of the list of what we're thinking, unless there was a really good reason to think that we might be missing something on the DAT. And similarly, with repeating the DAT with the prolonged incubation, because we're really looking at in vivo sensitization with the DAT, we're not incubating it with patient plasma. The incubation time really shouldn't impact the DAT results. So not something we would necessarily move to as a way of investigating a false negative DAT. So autologous adsorption being the favored answer here, but needing to know that transfusion history to interpret the positive autocontrol properly. Next question was, which of the following is not a low incidence antigen? So relatively softball question here. Answers that were given, 38% of, or 38 people are answering VGA, so the favorite answer, some answering LUA, 1 JSA, and no people falling for the KPA there. Covered the incidence of KPA antibodies. A little bit of discussion here, I guess, just around sort of what is a low incidence antigen. So it's technically like less than 1% of the population that expresses it. And if we're using that definition, actually LUA being present at 5 to 8% of people is not really a low incidence antigen, but it's kind of commonly referred to as a low incidence antigen. And similarly with JSA, depends a little bit on the ethnic background of the person you're talking about, or the population you're talking about whether or not it's a low incidence. So if you're talking about a primarily white population, yeah, it is a low incidence. It's only present in 0.01% of donors. But among Black individuals, it's actually fairly common at 20, or relatively common at 20%. So those were put in as answers more for discussion points, just around low incidence and what actually is a low incidence antigen and some of those differences. But the favorite answer here was the BGA, because BGA, which is the HLA-B7, is present in about 23% of donors. So really kind of no nuances about BGA being not a low incidence antigen, sort of favored here. All right, so getting back to our patient, the question was based on the serologic testing that we had. So again, showing the anti-KPA and hoping that we'd found some incompatibilities between the mother's plasma and the father's red cells. The question was, what can we conclude about the father of the pregnancy? So can we tell him that he should be informed that he's got a blood type that puts him at high risk of hemolytic transfusion reactions? That he should be encouraged to donate blood via the rare blood program? That we can't tell him anything. We just don't know anything working with the mother samples and his red cells, but can't really tell him much about that. Or that his red blood cells express a low incidence antigen. So in terms of responses we got here, we had most people answering that his red blood cells express a low incidence antigen, which was the favored response here. I think this one's relatively straightforward. Because the plasma of the mother is expected, we should be seeing reactivity between the mother's plasma and the red cells that were provided. It tells us that the mom having just the anti-KPA, the father is probably KPA positive. And if we think about where the mother's alloimmunization could have come from, or the sensitization would have come from, since the stem provided no transfusion, confirmed there was no transfusion history,
Hey, Deb.
any sensitizations have to have come from the father.
No, I'm not.
And so,
Hello, how are you?
oh, just have some background noise there.
Oh, here.
There we go. So C is not the right answer there. We do know that we can conclude the father's KPA positive. We don't have to tell him that he's got a blood type that puts him at high risk of hemolytic transfusion reactions because he's expressing the antigen. And so he's not really going to be at risk if he gets transfused with red cells of a hemolytic reaction because, if he ever gets a KPA positive cell, which won't happen very frequently, it's not at risk to him. He's not going to make an anti-KPA. It's the common, the majority that don't have KPA that are at risk of having a reaction if they get his red cells. So that's why A is not a great answer here. And in terms of whether or not he should be encouraged to donate via the rare blood program, so it's true, I guess, if you think about KPA being a rare blood type because it's less than 2% of donors, he's not really a very useful donor because his red cells express a KPA antigen. So we don't really want to be, we're not going to be looking for that as a transfused product for most people. So that's why B is not a great answer, leaving us with D as the right answer here. All right, so we're provided with ABO typing and a DAT results for a patient, with ABO typing showing the person is group O and their DAT is IgG negative and C3 positive. And the question is, which of the following tests would be appropriate in the further investigation of hemolysis? The options being screening for a cold agglutinin, which a lot of people picked, incubation of the patient plasma with O red cells in ice, followed by 37 degrees Celsius, repeating the DAT with a cold saline rinse, both A and B, or none of the above. And we had splits here between just screening for the cold agglutinin or doing both that and incubating patients' plasma with O reagent red cells in ice. And the suggested answer here would be A and B. Just want to make sure I copied the question down correctly because yeah. So thinking here is that we're looking at possibility of a cold agglutinin with the C3 being positive and the IgG being negative. But included in the differential of that DAT would be a Donat-Landsteiner antibody, which is an IgG that binds in the cold and then has a low thermal amplitude, but is able to recruit complement. So once the red cells warm to body temperature, the IgG disappears, but the C3 is left behind. And so option A would be useful because if we're thinking there's a cold agglutinin, screening for it would be helpful. And option B would be helpful as well, although it doesn't completely describe what would be included in the Donat-Landsteiner testing. So it wouldn't be the totality of what's being done, but would be something to consider potentially if we're thinking about a Donat-Landsteiner. And again, just as a reminder in terms of how the Donat-Landsteiner testing is done, we have a combination of patient serum, control serum, and a mix of both. And they're incubated at different temperatures, tested at just 0 degrees alone, 37 degrees alone, or a shift from 0 to 37 degrees. And so B would be part of the Donat-Landsteiner testing, so something to consider, but not done in isolation. So because that A and B is the suggested answer, but I can understand why you might pick A just because if you're thinking of B being the only thing you're doing, that's not a really kind of describing the Donat-Landsteiner testing completely. Next question, a cold antibody screen is positive for the patients in question 18. So this is the patient with this ABO typing and the DAT, I believe. And a panagglutinins present at immediate spin. So which of the following is true? So rest adsorption will absorb only cold autoantibodies. The negative antibody screen with a pre-warm sample excludes alloantibodies, or the rest adsorption may remove allo-IgM antibodies. So a bit of a split here in terms of answers. Interestingly, 6 people picked an answer that didn't exist. And between the other 3, relatively evenly divided. So the suggested answer here is C, the rest adsorption may remove allo-IgM antibodies. And just as a reminder about rest, so rest is the rabbit erythrocyte stroma. So it's a reagent that's provided that's red cells from a rabbit. And the theory behind it is that red cell, the rabbit red cells will stop up IgMs that are primarily cold and leave behind any other alloantibodies and IgGs that might be in the patient plasma. absorbing away IgMs and removing cold antibodies. The challenges with it and some of the pitfalls that have been recognized and nicely described in this paper that I provide the reference for is that it actually can remove clinically significant alloantibodies. So there's cases where anti-VELs have been removed, anti-Big E antibodies have been removed. So some allo-anti-IgMs, but including IgGs as well. So it's not as clean a reagent as we sometimes think about it. And so just something to be cautious of when we're using rest adsorption, that it's not only removing cold autoantibodies, we can remove alloantibodies with it. So I have to be cautious about over-interpreting, I guess, a sample that cleans up after rest adsorption. And the negative antibody screen of the pre-warm sample might help you to exclude alloantibodies, but it's not only autoantibodies that I guess that can be removed, or where you get the reactivity disappear with pre-warming. So you got to be very cautious about over-interpreting pre-warming as well, because there are well-described cases of alloantibodies that will pre-warm away. So it's not something that's unique to autoantibodies that pre-warming will get rid of them. And so C is the favorite answer here. So I think with that, I will pause. I don't know if there's any questions that came up. Just give a 15 minutes for discussion, and if there's any questions, you can put them in the Q&A if you haven't already. And thank you a lot for your attention.
Yeah, so just a reminder, if you do have a question for Dr. Mack, you can put it in the Q&A option or in the chat function, or just raise your hand and unmute yourself to ask your question. Michelle was asking, can I have the answer for question number 9? I missed it.
I didn't number my question, so can you tell me what the stem was for question 9? Go back and count.
Rochelle, can you let us know what the question was? You can type it in the chat if you want.
Is it this one? If this is question 9, the favorite answer was answer A. This was number 9. The favorite answer was B.
All right, so she said, which of the following must be performed with investigations for clinical? Yeah.
Yeah, so this one, the favorite answer was answer B, and that's just based on the CSTM standards. So they require not 3, but minimum of 2 reagent red cells for antibody screening. There's no requirement for pre-warming and no requirements for an enhancing medium, but the 37-degree incubation should be done before antiglobulin testing. That answers the question.
Okay, so Rochelle said thank you. Okay. Any other questions out there, or comments, or things that you just want explained a little bit better? All right, sounds like you've explained everything pretty crystal clear.
Excellent. All right. Well, thank you very much again for participating, and we'll see some of you for Tier 3 at the top of the hour. This session I mentioned at the start, but we'll end this session and then just relog in using the Tier 3 link. So it's sort of a separate team session for Tier 3 for those of you joining. And if you do have any questions that come to mind afterwards or concerns about the answers on the questions, you can email Tracy or myself. We can help to clarify. And I think, Tracy, did you mention about the certificates at the start?
No, I was just going to mention it now. And yeah, and someone was asking about the recording. So yes, you guys will be able to have the recording. We will have it all ready within the next couple of days. And your certificates. So we have to culminate the time for you guys completing the actual workshop itself with the samples and entering your results, as well as attending this session. So it will be probably next week before you will get your certificate for attending. And we do have one more question in the question box. Sorry, Johnny, question was from Laura, and it was, how would we know if there is, or if our screen is negative?
Yeah, I was not a totally fair sample because of that. So we were when we wanted to do an anti-KPA just to give people something they don't see all that often. But we were a bit worried about that happening, and I think that was one of the things we saw was that most people didn't pick it up on their screen just because it's not, our screening cells are not always going to have the KPA positive cells. So we included those paternal cells to try and help with that, just to try and get people to think, well, this is we're supposed to be finding something based on the questions, and so using those paternal cells as a way of guiding it. But it was just a bit of a limitation to sort of the workshop and trying to pick an interesting case, but something that people would actually find. So apologies to any of you who did some hair pulling trying to figure out what was going on there. Hopefully the discussion today was worth any stress that caused.
All right, so we will probably end this session then now and have a bit of a 10-minute bio break for those that will be rejoining again at 3 o'clock. Oh, there's one more. Oh, sorry, there's one more question there. The paternal cells definitely helped. The screen on mom was negative for me, but the fact that she had an incompatible cross-match with O-neg dad made me set up the panel.
Perfect. That's what we were hoping would happen, even though we're recognizing that you wouldn't have that sample. So we were hoping that would kind of be a bit of a tip off to people, be like, well, we should, if it's a maternal sample, let's check the two together and then do the panel afterwards. So again, not real life scenario, but just trying to make an interesting case and give people an interesting sample they might not encounter all that often.
Great.
Thanks a lot. Thank you, Tracy. Great. And again, a big thank you to everybody who helped support the workshop from the neural and ORBCoN sides.
All right, so we'll see most of you again in another 10 minutes or so.